Welcome to this Step 3 review on high blood pressure management, brought to you by Roadmap to Residency. We're not reteaching hypertension. We're showing you how the question writers build these vignettes and how to attack them fast. Blood pressure shows up constantly because it lives in the clinic and touches every organ system. We'll cover first-line agents by comorbidity, the workup of resistant pressure, drug combinations, and how home readings change your answer. Keep your question bank open. Let's begin. Here's the plan. First, choosing the first-line agent from the comorbidity buried in the stem, because the comorbidity chooses the drug. Second, the workup of pressure that stays high on 3 medicines. Third, combining medicines, including the trap pairs. And fourth, home blood pressure monitoring, which changes the answer more than you'd expect. We'll work 4 practice questions and explain why every choice is right or wrong. For the content, drill the blood pressure chapters in your board review resource and question bank. Strategy 1 is the most reliable move in this subject. Let the comorbidity choose the drug. The writers almost never give you high blood pressure and nothing else. They bury a second condition, and that condition is the answer key. So before you read the choices, scan the stem for it, then match. Protein in the urine, or diabetes with kidney damage, means a renin-angiotensin blocker, an ACE inhibitor, or an ARB. A prior heart attack, or heart failure with a weak pumping chamber, means a beta blocker plus a renin-angiotensin blocker. African ancestry without those conditions favors a calcium channel blocker or a thiazide water pill. Pregnancy means labetalol, nifedipine, or methyl-dopa. Memorize this cold. Find the comorbidity and you've found the answer. Strategy 2 is the workup before anyone adds a 4th medicine. Learn the definition precisely. Resistant blood pressure means the pressure stays above goal on 3 full-dose medicines, and 1 must be a water pill. If none of the 3 is a water pill, the answer isn't to hunt a rare cause. It's to add the water pill. Before accepting the resistant label, rule out the fakes. Wrong cuff size gives a falsely high reading. Non-adherence is the most common reason pressure stays high. And confirm readings outside the office. Once it's truly resistant, hunt the cause. Ask about drugs that raise pressure, the favorites being anti-inflammatory pain relievers, birth control pills, decongestants, and stimulants. Screen for excess aldosterone with the aldosterone to renin ratio, the most common hormonal cause. Ask about snoring and daytime sleepiness for sleep apnea. And consider narrowing of the kidney arteries and kidney disease. Those 5 cover almost every question. Now combining medicines and reading home numbers. First, combine across classes, never within. A renin-angiotensin blocker plus a calcium channel blocker works. A renin-angiotensin blocker plus a water pill works. The classic trap is an ACE inhibitor combined with an ARB. Both block the same pathway, raising the risk of kidney injury and high potassium without lowering pressure. That combination is always wrong. Second, start 2 drugs when pressure is far from goal, often as 1 combined pill, because that improves adherence. Third, home readings reveal 2 imposters. Office high but home normal is white coat hypertension, so keep monitoring. Office normal but home high is masked hypertension, and that patient needs treatment. The rule: when the stem gives home numbers, those are the numbers that matter. Our first practice question. A 52-year-old man comes in for a routine visit. His blood pressure is 148/92 and 150/94 2 weeks ago. He has type 2 diabetes. Labs show a small amount of protein in the urine with normal kidney function. He takes metformin only. What's the most appropriate initial blood pressure medicine? Before the choices, run the strategy. Find the comorbidity. It's right there in the labs. Read the options and commit. Let's break it down. 2 elevated readings on separate visits establish the diagnosis. Then the stem plants the comorbidity. Diabetes with protein in the urine. That protein is the whole question. Protein in the urine calls for a renin-angiotensin blocker because it lowers pressure and protects the kidney by reducing protein loss. Lisinopril is that medicine. Now the wrong answers. Amlodipine lowers pressure but offers no kidney protection. The right drug for the wrong patient. Hydrochlorothiazide has the same problem and can worsen blood sugar. Metoprolol is a beta blocker, not first line for uncomplicated hypertension. Every wrong choice ignores the kidney. The answer is lisinopril. The comorbidity chose the drug. Second question, a workup question. A 58-year-old woman returns because her blood pressure stays high. She takes lisinopril, amlodipine, and chlorthalidone at full doses every day. Her pressure is 162/98, and home readings are similar. Her potassium is 3.1. What's the most appropriate next step? Before you choose, check the definition. Is this truly resistant? Count the drugs, confirm one is a water pill. Then look hard at that potassium. Let's work through it. She's on 3 full-dose drugs, and 1 chlorthalidone is a water pill. Home readings agree with office, so it's not white coat. She takes them daily, so adherence is addressed. This is truly resistant. Now, the potassium of 3.1 is low. Low potassium with resistant blood pressure is the classic signature of excess aldosterone, and that number is there so you'd find it. Why does the hormone test win? Because the aldosterone to renin ratio is the screening test, and it must come before treatment. Start spironolactone first, and you corrupt the result. So adding spironolactone is tempting, and she'll probably end up on it, but that skips the diagnosis and the question asked for the next step. CT angiography is reasonable for resistance, but low potassium points to the hormone, not the artery. A sleep study has no trigger here. The answer is to measure the aldosterone to renin ratio. Test first, then treat. How to attack these under time pressure. First, read the last line, then hunt the comorbidity. The final sentence tells you whether it wants a diagnosis, a next step, or a treatment. Then sweep for 3 things: the comorbidity, the medicines the patient already takes, and the potassium. Those decide the answer more often than the blood pressure number itself. Find them in the first 15 seconds, and you'll answer most of these in under a minute. Second, drill the patterns until they're automatic, work blood pressure questions timed, and read every explanation, even the ones you got right, because that often reveals the rule you got right by luck. Then read the matching chapter in your board review resource. Questions teach the pattern. The resource teaches why it exists. You need both. Third question, about the home log. A 45-year-old woman is referred for high blood pressure. Her office readings over 3 visits are 152/94, 148/90, and 154/96, all clearly elevated. She feels well, no other conditions. But she brings a 2-week home log, averaging 118/74, taken twice each morning and evening on a validated upper arm device. Exam and labs are normal. What's the most appropriate next step? Notice how much detail they gave about that log. It's there because the log is the answer. Choose your option. Let's break it down. 3 elevated office readings with a normal home average is the textbook definition of white coat hypertension. And look how carefully they validated that log. 2 full weeks, twice each morning and evening, a validated upper arm device. Every detail tells you the log is trustworthy and beats the office numbers. Now the wrong choices. Starting amlodipine treats a number, and in a woman truly averaging 118/74, it risks dropping her too low. Starting lisinopril and hydrochlorothiazide compounds that, and 2 drugs at once, is for pressure far above goal, which she doesn't have. A sleep study has no trigger. She feels well. The answer is to continue home monitoring and reassess in 6 months. When the STEM gives a well-collected home log, the log is the truth. Fourth and final question, the combination trap. A 60-year-old man with heart failure and a weak pumping chamber has a pressure of 158/94 despite maximum dose lisinopril. Heart rate 78, kidney function normal, potassium 4.4, no leg swelling. What's the most appropriate medication change? 2 things should catch your eye. First, heart failure with a weak pumping chamber, a comorbidity that chooses drugs. Second, he's already on a renin-angiotensin blocker, so one answer is almost certainly the classic trap. Read all 4 and commit. Let's break it down. Heart failure with a weak pumping chamber, already on a maximum dose renin-angiotensin blocker, heart rate 78 with room to slow it, normal kidneys. The comorbidity chose half his regimen. Now it chooses the other half. Heart failure with a weak pumping chamber calls for a beta blocker proven in that condition, on top of the renin-angiotensin blocker. Cardiology does 2 jobs, lowering pressure and improving heart failure. Now the wrong answers. Adding valsartan to lisinopril is the trap, stacking 2 drugs on the same pathway for no benefit. Always wrong. Verapamil slows the heart and weakens contraction, harmful in a weak pumping chamber. Replacing lisinopril with amlodipine removes a drug treating his heart failure. The answer is carvedilol. Add, don't stack, and never subtract a drug doing two jobs. Here's the exam day pearl, the 4-question sweep. On every blood pressure vignette, before the answer choices, ask 4 things. What comorbidity is present? What medicines is the patient already on? What's the potassium? And are there home readings anywhere? Answer those, and the correct choice usually announces itself. That sweep takes 15 seconds, then commit. If it doesn't settle within 90 seconds, fall back on 3 elimination rules. Eliminate the option that stacks 2 drugs of the same class. Eliminate expensive imaging with no clue pointing to it. And eliminate treating an office number when a good home log disagrees. Choose whatever survives, flag it, and keep moving. Never let one vignette eat 3 other questions. That wraps up our review of high blood pressure for Step 3. Let's lock in the core ideas. First, the comorbidity chooses the drug. Protein in the urine or diabetic kidney damage means a renin-angiotensin blocker. A prior heart attack or heart failure means a beta blocker on top. African ancestry without those favors, a calcium channel blocker or thiazide. Pregnancy means labetalol, nifedipine, or methyl dopa. Second, before a 4th medicine, confirm truly resistant on 3 full-dose drugs including a water pill, then hunt the cause, and low potassium points to excess aldosterone. Test before you treat. Third, combine across classes, never within, because stacking an ACE inhibitor and an ARB is always wrong. And fourth, when the stem gives a good home log, the log is the truth. Drill these questions timed until the 4-question sweep is automatic. Visit roadmap-to-residency.com for tutors and advisors. If this helped, please like and subscribe. Good luck on your exam.